Dr. Balaji Mohan. I'm a practicing physician and a diabetologist with the Apollo Sugar Clinics at Bangalore. I'd like to talk about the case study that I had given for publication. This is regarding Fibrocalculous Pancreatic Diabetes, also known as FCPD or Tropical Calcific Pancreatitis or Type 3C diabetes. So here I had a 51-year-old gentleman who came to me in 2014 with a history of diabetes for the last 3 years. And further probing, I came to know that basically he was managed on sulfonylurea, on a DPP4 inhibitor, and metformin, and his HbA1c was around 7.2. He did give a history of a recent abdominal surgery, and on probing, it was discovered that he underwent a sphincterotomy with sphincteroplasty and a stent placement in the main pancreatic duct with a partial pancreectomy and stone removal from the pancreas. So that gave me an idea that probably we're dealing with a different type of diabetes. And he did show me some of the imaging reports that were taken before the surgery. And an X-ray abdomen as well as a CT abdomen clearly pointed out stones in the head of the pancreas, multiple calculi, and dilatation of the main pancreatic duct. Further, probing into the history, I could find out that he had a history of childhood abdominal pain with steatorrhea, and also there was elevated pancreatic function test. So amylases and lipases were on the higher side. So putting all these presentations together, it was clearly evident that he had a different type of diabetes, and it was pointing out towards a fibrocalculous pancreatic diabetes. Then further, I asked for a C-peptide. C-peptide showed a near normal value, almost towards the lower limit of normal for fasting and postprandial values. And now putting the entire picture together, it was obvious that it's a secondary form of pancreatic diabetes that we're dealing with. So I stopped the DPP4 inhibitor. I changed the patient to basal bolus insulin, low dose of glargine with glulisine, continued sulfonylurea, that is glycoside, removed the metformin because of the GI intolerance. And now the patient has been coming to me for the last 10 years, and his sugars are more or less well managed, and the HbA1c has been around 7 to 8. So in between, I had even put him on an SGLT2 inhibitor like canagliflozin. And I think this is the first time for a condition like FCPD and SGLT2 inhibitor has been tried, because it's an off-label indication. And remember that these people, FCPD people, are never prone to ketosis. They have some amount of beta cell reserve. So this patient now being diagnosed with secondary FCPD is now treated with basal bolus, sulfonylurea, and an SGLT2 inhibitor, and he's doing well for the last 10 years. Now, what are the points to remember in order to clinch a diagnosis of FCPD? Always these individuals will be from a tropical climate. They will have multiple calculi within the pancreas, either in the head or in the tail or even in the body of the pancreas. You need to do imaging tests. So an X-ray abdomen or an ultrasound or a CT abdomen will help you to clinch the diagnosis. And sometimes there will be abnormal pancreatic function tests as well. And probe into the history, where you will have a history of childhood abdominal pain with steatorrhea. And remember that DPP4 inhibitors or GLP-1 agonists should not be given to these patients because they have chronic pancreatitis and it is contraindicated. Always use insulin. You can use short-acting sulfonylureas, and SGLT2 is something that I've tried for this patient. This is the case study that has been accepted for publication. Thank you.